Hi, my name is Rohit Patel. This is an introduction to the curriculum here at University of Florida Health. Our mission statement is to promote point-of-care critical care ultrasound, education, diagnosis, and research. Most of the information contained in the didactic lectures is through a few textbooks. One is critical care ultrasonography, and one is whole body ultrasonography in the critically ill. Although other articles are used in most of the compilation for the didactic lectures. First, I'd like to talk about our education component. Our curriculum is based off of two large papers, one from the Society of Critical Care Medicine called Toward an Ultrasound Curriculum for Critical Care Medicine, and the other one is from CHEST, which is also a consensus statement from the American College of Chest Physicians on competence in critical care ultrasonography. Most of the curriculum developed through this program or throughout the year is with the hands-on and active learning portions is also based on recommendations from these two bodies. All the information in the curriculum is also found on the website, ines.ufl.edu/ultrasound. There we have our curriculum, our competencies from the ACCP, tip sheets, self-learning tests, didactic material, as well as all the instructional videos and journal clubs we do. We have a list of videos for immediate bedside help. These are all 5 minutes or less. We have a critical care ultrasound conference that we do yearly for faculty. And we have many medical school educational sessions that we do with emergency medicine. The training modules are broken down into 10 to 11 different sections, starting with introduction, basics, then going to vascular, abdomen trauma, lung, echocardiogram basic, procedural guidance, and then advanced lung and echo, as well as shock. Kind of goes through starting from basic to what you would imagine yourself doing ultrasound in the critically shocked patient. It's important to get improved in all the basic applications before you use them in the shock state. Each of the module components have a few components that I would like to talk about. First, there are self-learning tests for individual sections. There's a pre-test and a post-test. This is mainly in order to get you some basic ultrasound knowledge. Competency goal review, I feel, is very important. Before each module, I have competencies that you should know by the end of the module, and it's good to review it throughout the module, and also periodically throughout your training period to come back and make sure you understand these are the important parts of the ultrasound curriculum that you should know how to do by the end of the curriculum. All these are based off of the American College of Chest Physicians competency goals. The didactic lectures are 15 to 20 minute lectures that are more knowledge-based and less image-based. And they should be like an introduction to that particular topic. The bedside videos are all 5 minute or less videos, with its function is to help you actually analyze what probe you should use and where you should place the probe on the patient, and a more hands-on learning experience of what you would do at the bedside. And they're made to be 5 minutes or less so that if in the course of your training you want to go back and remember how to do, for instance, lung ultrasound for pulmonary edema, well, then there's a 5 minute or less bedside video kind of telling you which views you should be looking for. The active learning part of each module actually engages you to go to either the unit that you practice on or the emergency department where you practice to go and actually obtain images. And this part of the curriculum I feel is very important because if you don't actually get better with your hands-on skills, it's very hard to improve your ultrasound in settings where you really need to use your ultrasound. For instance, if a patient is too unstable to go to CAT scan or is acutely sick, hypotensive or hypoxic, and you don't have the tools necessary at the bedside besides ultrasound. The reading material is a more in-depth knowledge base for you, and it's very important to take your time and go through these the articles that we have placed on here, because even though some of it may be more complicated than you need to know, it's something important for your overall ultrasound curriculum. Then there's a section called sample clip reviews, where there's no testing material. It's really just going through a bunch of abnormal clips. And I feel this is, in the part of the module, is very important to go through this and be able to see abnormals before you find them on your patients. Another part is called observed learning. These are typically at the end of each of the modules, where after you have done a lot of reading, a lot of bedside videos, a lot of active learning, you actually find a faculty advisor. We have at least 2 or 3 in each department that I know of that are deemed like the ultrasound faculty, and each one of them will be more than happy to complete one of these forms with you. Essentially, you print out one of the forms and you go to the unit where you practice, and you have one of them observe you so that they can identify gaps in your training. We have quality assurance review every 2 weeks in the surgical ICU ultrasound curriculum. Every 2 weeks we have a 20 to 25-minute lecture followed by quality assurance review. I actually review all the ultrasound done in the surgical ICU. In each area, medical ICU, cardiac ICU, and pediatric ICU all have ultrasound champions who also are doing quality assurance in their respective departments. Then I have a part called speed training, and the reason I put this in all the way at the end is after you have done all these other things where you familiarize yourself with the machine, with reading material, with the didactic lectures, part of it is sometimes you'll be doing these ultrasounds while the patient is hypotensive with a blood pressure of 60/40, and you have 18 other things going on in your head that you need to do. And I want you to be really fast with the ultrasound, meaning very fast with turning it on, getting comfortable with it, and kind of using it without actually even thinking about using it. Kind of like what you do when you drive your car, or you do other complex procedures that you've done so much of that you don't actually think about as much. And the last is kind of case scenarios, where each of these modules has 5 to 10 case scenarios where it gives you a case of a particular patient, and you can kind of go through it and see what your management decisions would be. Because ultimately, your goal at the end of all this curriculum is to be able to synthesize multiple ultrasound applications as well as other measurements that you've normally had in the past, such as CVP, PA catheter measurements, clinical exam, and use the ultrasound as another step for you to use to make your final decisions on your patients. So the diagnosis part comes from our education curriculum also. There are many articles that talk about focused cardiac ultrasound in the emergent setting. There's international evidence-based recommendations on lung ultrasound and also point-of-care ultrasonography. And our goal is to improve the diagnosis in our respective areas so that we can take care of our patients better. This just shows that goal-directed echo in hemodynamically unstable patients performed at the bedside by the physician caring for the patient can provide immediate critical information about the cardiovascular system that is not available by any other means and can impact therapy in 30 to 40% of patients. Now, this is just one article, but there have been many other articles that have similar results. In order to be able to diagnose, we have to have machines. We have to have adequate machines, newer machines, more portable machines, and definitely machines that are fast to boot up. As you can see, each of these machines, now we have wireless communication where they get saved to our servers. And that's needed for accurate diagnosis and accurate billing, which I'll talk about in a few slides. Also, at the University of Florida here, we have procedure notes. So as every ultrasound that you do, remember we're making patient decisions with them, you should do a procedure note. We have templated notes in the procedure notes. The smart phrase is .uscc. These notes are templated so that we can bill, we can also use them as a standard template for all the intensive care units and emergency medicine settings where we use bedside procedural ultrasound. This will decrease errors and help solidify our use of bedside ultrasound. And all the directors of each unit have told me that they are willing to use these templates, and if there are any issues with the templates, that we can change these on a as-needed basis. There's also some information in this curriculum on billing. We are, in most of the ICUs, billing for a lot of these procedures, such as vascular access, as well as basic echo. We also do ultrasound of the chest for pleural effusions. The last part is research, which is always the hardest part to improve on, but you have to have the other two components and have people willing and ready to learn. But we do have research and interest meetings once per month in the surgical ICU. They occur right after our lecture. The goal is to have multidisciplinary between the emergency department, who has an emergency ultrasound fellowship, the medical ICU, the surgical ICU, cardiac ICU, and neuro ICU, all which have fellows that use ultrasound all the time. Some of the projects that we have done in the past are Dobhoff tube location, pneumothorax evaluations, muscle ultrasound for nutrition, ocular ultrasound for intracranial pressure, and we have other ones pending for sepsis and ultrasound in renal failure. Also, we have tons of case reports. We have a system called QPath, which is very important for each one of these missions, the education, diagnosis, and research. For instance, in the education, scans done in the ICU and emergency medicine all get reviewed. Diagnosis allows communication between the images and the machine and either McKesson, PACS, iSight, wherever you're going to store them. Research allows a system in place for safe storage of research data. You can actually make reports such as this for individual ultrasound trainees. Check with your unit director for who does the ultrasound and who reviews all this to see how you can be involved in this process. As a final slide, what we want to talk about is things that we're doing to improve our curriculum, and we essentially do a critical care ultrasound conference every year for adult and pediatrics. We have bedside videos for common problems in the ICU, such as like hypotension, hypoxia, as well as all the basic applications. We help medical students and nursing with education. It seems like everybody wants to learn ultrasound, and I think part of the reason is because everybody knows that it helps take better care of their patients. And the last is improving our research ultrasound, which we have uses in weaning for mechanical ventilation, increasing cranial pressures, and mainly sepsis, use in sepsis. So as you can see, the curriculum is very robust, and hope you continue to learn throughout it. And by the end of the curriculum, you should be a very good bedside ultrasound sonographer for critical